So on the chart, this is for Dr. Rollins. So on the chart for unfractionated heparin, it was recommended to check PTT or anti-10A levels. But that correlation is unreliable. Thoughts, agree, disagree?
I would just say as a general statement for the unfractionated heparin, PTT is, sort of the measure that's being recommended. And again, it comes down to timing as part of your clinical decision because they don't come back instantaneously, but I think it's a measure that can help your decision on what to do, assuming you have time to do that. And I don't want to speak for the committee, but I think that's why they recommended it.
Okay, thanks. So, Dr. Bateman, with the early warning triggers, given the diversity among hospitals, how would you propose that there would be a development of standardization as has been challenging for standardization in fetal heart rate monitoring?
Yeah, I mean, I think first and foremost we need data, so we need studies to be done that compare the performance characteristics of the different trigger tools that have been proposed. We need studies that work to optimize them to figure out what the heart rate and blood pressure and O2 sat threshold should be for triggering. I just think a lot more research needs to be done to before a definitive tool can be recommended. And then even then, once we have all of those data, the trade-off is always going to be between sensitivity and specificity. The more strict you are in requiring extreme vital signs for triggering, the less sensitive your tool is going to be, and when you go the other direction, you're going to become more sensitive but less specific. So, yeah, I'd say more work to be done.
Okay. So, Dr. Lim, who administers / prepares TXA at UCSF? Is it the RNs, anesthesia?
So currently, anesthesiologists administer TXA at our L&D unit. However, we are trying to develop protocols so that nurses can safely administer the TXA. So this protocol may be upcoming in next 2 to 3 months.
Okay. Dr. Rollins, so you had presented data on various gestational age dosing for heparin. What are your thoughts about obesity and anticoagulation? What should they change the doses, increase?
I think what it does is it adds a lot more variability to it. I mean, as a general statement that maybe I didn't make during the talk is low molecular weight heparin has a lot more predictability than unfractionated heparin, and that there are some societies, I believe the Canadian Society is one of them, that doesn't even use unfractionated heparin anymore for prophylaxis. There is some talk going forward that in a few years you may see just movement towards low molecular weight heparin for thromboprophylaxis in the US and just getting away from the unfractionated heparin. But back to the obesity, it definitely does affect things. It's also in itself a risk factor for VTEs. And in addition to the variability, it needs to be taken into account for the prophylactic measures.
Dr. Bateman, when triggers are incorporated into the EMR, is it done by the hospital IT, or does Epic personnel do it? How do you get started with that?
So that was built before I went to the Brigham, so I don't know exactly the process by which they coordinated with, or our group coordinated with Epic to make that happen. I know it was done at the time of the initial Epic rollout, but I don't know about the logistics of that.
Okay. Dr. Rollins, for therapeutic dosing for patients with pre-E or with, I guess, Lovenox and heparin, what do you suggest for those who have severe pre-E? So basically, if it's Lovenox or heparin, do you change the dose, or how do you think about it for someone who has severe pre-E and has obviously end organ damage? So,
I see. I understand.
Creatinine levels.
They did not give specific recommendations, but obviously, if you feel the kidneys are being affected, you would want to sort of, I don't know that I would say change the dosing, but assume that you're going to have a greater effect and maybe change your clinical decision-making to compensate.
So, Dr. Lim, you mentioned cell salvage, and when you think about when you use cell salvage in Jehovah's Witnesses, if there is a primary C-section for a patient and they're not willing to accept any blood products, would you use cell salvage, and would you tell the obstetricians you needed to wait for the cell salvage group to get there?
So it's sort of like emergency.
It's not. It's a primary routine C-section.
So it really depends on the patient risk factor, what kind of hemoglobin indices the patient has, and what other comorbidities the patient have. If also like the patient understanding of like what other products she may like willing to accept besides like cell salvage such as albumin and other part of their blood products. So it really depends on patient. Yeah.
Okay. Would you also, Dr. Lim, would you use prophylactic use of TXA?
Currently, there's no much data for prophylactic use of TXA, so we don't have a protocol in our institution for prophylactic use.
Okay. All right, I'm trying to read what this acronym is, but I'll just read it out. So, is it allowable to continue, this is for Dr. Rollins, to continue unfractionated heparin in a patient with I think it's a continuous labor epidural. No, CLE for labor. CLE, am I?
Yeah, continuous labor epidural.
Yeah, for labor, okay.
For labor. So it depends on the dosing. So the recommendations for the unfractionated heparin are once the catheter is in place and you've waited the appropriate amount of time, you can use the 5,000 BID dosing with an indwelling catheter.
Okay. So this is a question for Dr. Lim, but it would be something I think all of you could answer. So during unexpected hemorrhage in a C-section greater than 1,000 cc's, can you blindly give 1 gram of TXA along with massive transfusion protocol? Any concerns with TXA?
I would look into the patient risk factor again. This patient has any thromboembolic risk factor, or if not, I believe we'll start giving TXA along with massive transfusion protocol, and we can even get second dose of TXA if this hemorrhage continues after 30 minutes.
Mm-hmm. Any other thoughts? Yeah.
So, I mean, my reading of the women trials, the main thing it teaches us is that TXA is very safe. And so if a patient hemorrhages and when we're at 1.5 liters of blood loss or so, I think about giving it to just about every patient.
We have it in our protocol that once they clear 1,000 cc's, assuming there's nothing abnormal regarding risk factors, that we would give the TXA.
So each of you, would you, what would be a reason where you would not give it? What risk factors specifically would you not give TXA?
History of VTE during that pregnancy.
Okay, prior pregnancy or that pregnancy?
I think prior would be low risk.
Okay. And any any diseases where you think they inherently have some, not that they've had a DD, but any of the thromboembolic risks that you had listed on the board, would there be anything that you would?
I mean, guess just as a general opinion, I would go back to the sort of ACOG guidelines I laid out for low and high risk, and I would not be that concerned about the low risk, but I would be personally concerned about the high risk, but I also want to say this is not data driven,
right.
This is just my opinion.
Okay. Anybody else? Any thoughts?
Yeah, I think that's a reasonable approach for someone that's at exceptionally high risk of VTE to maybe avoid it in that circuit.
Okay, that's all the questions we have. Thanks you guys for sticking around to the end. And I will see you tomorrow and sign in.